Hi, I'm Michael Mestick, and I lead the Medical Affairs program on respiratory compromise. Prior to joining Medical Affairs, I worked in research and development, where I specialized in technology development for non-invasive respiratory monitoring devices, including both pulse oximetry and capnography. I now lead our scientific efforts to generate evidence demonstrating the value of these same technologies. One example of this work that I'll be discussing today is a recent systematic review and meta-analysis on the utility of capnography monitoring in procedural sedation and analgesia. These are my disclosures. These are the program's disclosures. Our objectives for this presentation are to first understand the importance of respiratory compromise. Then we'll take a closer look at what the scientific literature tells us about the value of continuous non-invasive monitoring with pulse oximetry and capnography. We'll delve into the 3 physiologic pathways that lead to respiratory failure and arrest, and we'll also assess the performance of different patient monitoring device options that are available to you. We'll then learn about how waveform capnography in particular provides clues that guide clinical interventions, and finally we'll explore the recent medical society statements to better understand their recommendations. Leah Kufel was a young girl who had a successful operation to repair her sternum. She was in considerable postoperative pain and given increasing doses of fentanyl and then Ativan because she was perceived as being anxious. Her mother kept a watchful eye on her and fell asleep for a mere 2 hours, only to wake up to find her daughter tragically unresponsive. Leah passed away that night in part because she wasn't being monitored. Her mother has now gone on to become an advocate for continuous postoperative monitoring for all patients receiving opioids. Logan Parker had an outpatient procedure to have his tonsils removed and septum repaired. Like Leah, he was receiving pain medication postoperatively. During the drive home from the procedure, his mother, who's a PACU nurse, noticed that he was becoming increasingly non-responsive, and ultimately Logan stopped breathing once he was at home. He was transported to the hospital, but resuscitation efforts were unsuccessful, and he was pronounced dead in the emergency department. His mother, Pamela, shares this story to advocate for better continuous respiratory monitoring with both pulse oximetry and capnography for patients on postoperative opioids. According to the Respiratory Compromise Institute, respiratory compromise describes a deterioration in respiratory function in which there's a high likelihood of decompensation into respiratory failure or even death, but for which timely specific interventions might prevent or mitigate decompensation. Identifying these respiratory compromised patients is critical because appropriate interventions that avoid catastrophic events can only be accomplished if this is done effectively. With that definition in mind, let's look at the extent of respiratory compromise. This is something that's extremely common. It's the leading cause of ICU admissions, rapid response team, and code blue calls. And for perspective, this is something that occurs in 1 of 9 elective surgery patients. Respiratory compromise is also costly. The inpatient cost alone is going to surpass $37 billion within the next couple of years. Although I'm using U.S. Medicare data here, I believe this is directionally true around the world. Based on numbers like this, the Agency for Healthcare Research and Quality determined respiratory compromise is among the top 5 most rapidly increasing hospital costs. And of course, respiratory compromise can be deadly. Patients who develop it on medical or surgical floors are nearly 30 times as likely to die compared with those who don't. And finally, the good news. Respiratory compromise is often preventable. Almost 2/3 of primary respiratory arrests have been classified as avoidable. And I'll also point out here that almost 3/4 of in-hospital cardiac arrests are also considered avoidable. Given the complexity of cardiorespiratory interactions, it stands to reason that a good proportion of these cardiac events had a respiratory antecedent, which further highlights the importance of preventing respiratory compromise. To examine who's at risk for respiratory compromise, we have to recognize that each patient may have differing risk levels depending on a few key factors. These may be related to the individual patient, such as BMI, comorbid conditions, or previously unknown diagnoses. Risk may also be related to treatment factors, such as previous anesthesia, type of surgery, or other medications that are administered. Risk may also be related to area of care and things such as the nurse-to-patient ratio, the frequency of vital signs checks, or the standard of care for monitoring. Fatal combinations of these factors produce a perfect storm, resulting in tragic consequences like we saw for Leah, Logan, and their families. We can hone in on a couple of specific patient cohorts to discuss risk stratification. The first is patients at risk for opioid-induced respiratory depression. Quite simply, opioids interact with ventilatory control mechanisms in the brain, so they can cause respiratory depression. Let's first consider patient-related risk factors that are known to increase risk. There are several related to sleep, which likely isn't a surprise. These may be sleep apnea or sleep disordered breathing diagnosis, morbid obesity with a high risk of sleep apnea, or snoring. Age is also directly related to risk, and you can see that older age proportionately increases the risk of respiratory compromise. Traditional lifestyle factors such as smoking increase risk, as do pre-existing conditions such as pulmonary or cardiac disease or even dysfunction and any major organ failure. Beyond these patient risk factors, there are several other considerations. Some of them are related to opioid drugs themselves, such as not having recent opioid use, so patients who are opioid naive, or conversely, do patients have an increased opioid dose requirement because of opioid habituation? Other sedative drugs are a critical factor and can compound the cardiac and respiratory risk that are associated with opioids. Drugs to consider include benzodiazepines, antihistamines, and other central nervous system depressants. Factors related to the procedures themselves also modulate the risk. For example, after surgery, patients who had upper abdominal or thoracic procedures are invariably going to be at higher risk. And even simply having a longer length of general anesthesia will increase the risk for respiratory compromise. Let's break down procedural sedation the same way. From a patient perspective, many of the factors are quite like what we just discussed. But there are additional unique considerations for this environment. These relate to the choice of the sedative and how it's administered. Also, procedure length itself is a risk factor, with longer procedures producing higher risk. Staffing factors are also key, as is the level of education and awareness of the staff that patients are at risk for respiratory compromise. Patient positioning, particularly those in the prone position, deserve special consideration. And finally, since the procedures are occurring outside of the operating room, monitoring is likely to be less comprehensive. Risk stratification has some limitations when it comes to patient monitoring. The Anesthesia Patient Safety Foundation points out that selectively monitoring is likely going to result in missing some patients who are at risk but don't have these traditional risk factors. The respiratory compromise cycle starts with the patient pathway and risk as we previously described. If that risk is realized, patients are likely to enter into a state of respiratory insufficiency. Here, changes in clinical presentation or monitoring parameters might be subtle, such as increases in respiration rate or work of breathing. This is obviously the crucial time for early identification because the interventions that accompany changes like these are not likely to be overly intensive. They might include things such as increases in supplemental oxygen to maintain SpO2. A patient progresses from respiratory insufficiency to failure or arrest when they're not able to compensate and oxygen and/or carbon dioxide levels start to shift significantly outside of normal ranges. For example, as those monitored parameters fall outside those normal ranges, an early warning score might trigger a rapid response team. Once the patient's decompensation is identified and reacted to clinically, the process of managing respiratory failure and returning the patient towards health is going to begin. Ultimately, the patient has to be prepared for a transition back home or to an alternate site facility. As we move from the patient pathway to the clinical objectives, we can break this into two parts, prevention and recovery, separated by the point of intervention. If we look at prevention first, again, early identification and intervention are the key here because the earlier these steps occur, the less the intensity of intervention required. For example, maybe a medication change is required versus the need to rescue the patient so workflow disruption is minimized because it's likely that a single respiratory therapist or nurse can make that change versus having a team of people respond. And of course, the cost will be less with these small changes in care versus what it would cost to activate that rapid response team or even transfer the patient to the ICU. Currently, most hospital models are focused on later intervention, but it would be preferable if they'd move the point of intervention up in the cycle to the point of development of respiratory failure, and ideally while the patient is in early development of respiratory insufficiency. This would spell greater opportunity for favorable respiratory compromise patient outcomes. Once the intervention occurs, the second half of the cycle is focused on recovery of the patient. Again, recovery is generally much easier, less costly, and has better outcomes for the patient when the intervention occurs earlier in the respiratory compromise cycle. Specific strategies and interventions in recovery need to have the goal of preventing further damage and efficiently restoring the patient to as healthy a state as possible. There are many conditions that may lead to respiratory compromise. The discussion becomes daunting when approaching it disease by disease or even in multiple groups. To aid in the discussion of how to best monitor and intervene, it's helpful to recognize that there are only 3 pathways to the development of respiratory failure. All conditions fall into one of these pathways, and in some cases 2 or even all 3 of these pathways may overlap. It may be helpful to set the stage for each type of respiratory failure with a real-world example of each that clinicians see on a regular basis. These case studies were drawn from the reference in the bottom of the screen. Here's the first scenario: hypoxemic respiratory failure, also known as oxygenation failure or type 1 respiratory failure. The patient is a healthy male who undergoes elective surgery and develops shortness of breath. The clinician, who is a nurse, notes a normal oxygen saturation reading on his pulse oximeter and reassures the family that he's okay. But his respiratory rate rises to a critical level, but that's noted too late to effectively respond, and the patient, who has sepsis, ultimately dies. The primary issue in this case is a decreasing ability to oxygenate the blood due to congestion in the lung tissue. So examples of this might be pneumonia, ARDS, sepsis, heart failure, or even other things. Irrespective of that, all of the interventions are going to be aimed at clearing congestion and improving oxygenation. So now let's take a look at what the monitor may tell us in this situation. To orient you, we have arbitrary units from multiple monitoring parameters on the y-axis that are going to change as a function of time on the x-axis for each graph that we show like this. The first thing that you'll notice is that even without supplemental oxygen, because of the plateau on the oxyhemoglobin dissociation curve and the curve shifts that may occur during changes in pH, CO2, and other factors, as a general rule, hemoglobin essentially holds onto oxygen at higher blood oxygenation levels and releases it faster as the arterial oxygen tension drops. This causes SpO2 to be a relatively slow change, as we'll see compared with the other parameters. And a typical first response of clinicians is to give supplemental oxygen or to increase the oxygen flow if the patient is already on supplemental O2, which is going to ultimately further delay that response. Let's look at respiratory rate next, because as a compensatory response to sepsis develops, the patient tries to breathe faster, which increases rate, and then deeper, both of which are going to increase minute ventilation. At this point, the patient's work of breathing has likely increased, and they may appear to be short of breath or complain of dyspnea. As the patient begins hyperventilating, CO2 trends will drop over time. To come back to SpO2, we see that it is maintained above 90 through a significant drop in arterial oxygen saturation due to, again, that plateau on the oxyhemoglobin dissociation curve, the patient's compensatory increase in minute ventilation, and the likely use and even increase in supplemental oxygen. So those SpO2 drops are going to lag significantly behind changes in CO2 and respiratory rate. Next, let's look at hypercapnic respiratory failure. To set the stage, here we have a healthy female receiving routine post-op nasal oxygen who is up all night complaining of severe post-operative pain and now asleep after being given multiple doses of IV opioids. So the nurse, noting a normal oxygen saturation, decides not to awaken her to do a routine vital sign check. The outcome of this is that she's found dead in bed 4 hours later. This is an example of hypercapnic respiratory failure, where the primary issue is inadequate ventilation to clear carbon dioxide, so hypoventilation. And this may result from opioid use, sedation, brain injury, obesity hypoventilation syndrome, or other things. And the interventions here are going to be aimed at improving ventilation. So these may be things like airway maneuvers, reducing respiratory depression, or providing the patient with ventilatory support. If we turn to what the monitor tells us in this scenario, we see that first, for the same reasons discussed in the last case, there'll be a time lag in SpO2, even if the patient is not on supplemental oxygen. And that's what provided our clinician with a false sense of security. Next, let's look at respiratory rate, which is normal or even decreasing. So that's not providing us with much definitive information. In this case, minute ventilation is decreasing as a result of hypopnea or shallow breathing. We see increasing levels of CO2, providing us with a very early notification of the problem that we're seeing in this case. Tidal volumes that are near dead space are going to result in low individual end tidal carbon dioxide readings. And then if the patient takes a normal breath with that alveolar plateau, the reading will be trending higher. It's important to understand that true end tidal carbon dioxide readings are only provided when the patient is breathing at normal tidal volumes. And that's a volume that's sufficient to produce a true alveolar plateau on the waveform. To foreshadow a bit what we'll be discussing around societal guidelines, SpO2 is maintained above 90% through a significant and dangerous rise in carbon dioxide levels. And this is further masked by the use of supplemental oxygen. Therefore, ventilation monitoring is so important in cases like this. For our final case, let's take a look at sleep-disordered breathing failure. Here we have an otherwise healthy male patient with undiagnosed sleep apnea who receives post-operative opioids for pain management. So clinically, a respiratory monitor is going to alarm repeatedly, lasting for about 30 seconds and then stopping, only to repeat over and over again. The nurse walks into the room to check on the alarm, and she awakens the patient, who states that he feels fine and is pretty much alert, requesting more pain medication. The nurse, who may be suffering from alarm fatigue, stops responding to the alarm, but later that night the patient is found dead in bed. This is an example of arousal failure associated with sleep-disordered breathing. Here the primary issue is one of recurring apneas and/or shallow breathing, hypopneas, during sleep, followed by periods of normal breathing or hyperventilation, which is aimed at restoring blood oxygen or carbon dioxide levels. These apneas or hypopneas may be obstructive, so there's still an effort to breathe, or they may be central, where there is no or insufficient effort to breathe, or they may be mixed, being a combination of the two. This repetitive pattern may happen multiple times per hour and is generally measured by the apnea-hypopnea index. Generally, reductions in oxygen and elevation in carbon dioxide during hypoventilation are going to cause an arousal, so the patient wakes up from sleep, which triggers normal ventilation and even hyperventilation to restore those oxygen and carbon dioxide levels. This arousal and recovery response might be blunted by opioids or sedatives or alcohol or other factors, which may lead to arousal or recovery failure and ultimately a terminal event like we saw in this case. So here we take note of many of the interventions are actually being focused on management of undiagnosed sleep-disordered breathing. Let's take a look at how this manifests on the monitor. You'll notice a sawtooth pattern of decreases and increases in respiratory rate, minute ventilation, SpO2, with reciprocal changes occurring in CO2. So essentially, arousal failure is a pattern of repetitive reductions in airflow and SpO2, with corresponding but reciprocal changes of increasing carbon dioxide during sleep. And all of the parameters monitoring reflect this. Let's delve into the evidence around patient monitoring in two key areas for respiratory compromise. The first is opioid analgesia, the second, procedural sedation. The American Society of Anesthesiologists keeps a closed claims database that provides useful insight into both of these areas. From the postoperative perspective, about 3/4 of the claims where respiratory depression was identified resulted in severe brain damage or even death. The vast majority of these events occurred within 24 hours of surgery. In nearly all of them, were judged by the authors to be preventable with better monitoring and response. Finally, they reported that the time between the last nursing check was as little as 15 minutes for up to 16% of those claims. This suggests that continuous monitoring may have been a viable path to prevention. If we turn to sedation outside of the operating room, we see similarly that over half the claims from oversedation were deemed to be preventable with better monitoring. And in monitored anesthesia care specifically, respiratory depression was the most common specific damaging mechanism after sedation medication overdose. The question then becomes, can continuous non-invasive respiratory monitoring help identify these events earlier? Recently, a study was published looking at the effectiveness of continuous pulse oximetry and capnography postoperatively. These authors conducted a systematic review and meta-analysis of previously published work focusing on adult patients on opioid analgesia during recovery from surgical procedures. They specifically looked at the effect of these monitoring technologies on oxygen desaturation, bradypnea, and hypercarbia, in addition to rescue team activation, ICU admission and mortality, and they identified 9 studies that met their predefined inclusion criteria, and the main takeaways were that pulse oximetry improved the detection of respiratory depression compared with clinical spot check. It's also interesting to note that there was a reduced trend towards ICU transfers with continuous pulse oximetry, and in one prospective randomized study, continuous pulse oximetry significantly reduced ICU transfers, specifically due to pulmonary complications. Their results also indicated that capnography provided an earlier warning of postoperative respiratory depression than pulse oximetry, which may be particularly important for patients receiving supplemental oxygen. Next, we'll look at a recent meta-analysis in procedural sedation and analgesia. So procedural sedation during endoscopic procedures is intended to increase patient comfort by reducing consciousness and pain while allowing the patients to still breathe spontaneously. However, procedural sedation-related adverse events do occur, and they commonly include severe oxygen desaturation, bradycardia, hypotension, and cardiac arrest. Here we conducted a systematic review and meta-analysis of 13 randomized controlled trials that compared standard of care monitoring with or without capnography during gastrointestinal procedures. In aggregate, these studies demonstrated that capnography monitoring is associated with less mild and severe oxygen desaturation, as well as the need for assisted ventilation. In light of both the evidence that we just reviewed and expert opinion, several societies have issued statements emphasizing the importance of continuous non-invasive respiratory monitoring for patients on postoperative opioids. The Joint Commission, for example, the American Society of Anesthesiologists, and the Anesthesia Patient Safety Foundation have all stated that it's important to monitor both oxygenation and ventilation levels in these patients. Ventilation monitoring is particularly important because many, if not most, patients are on supplemental oxygen, which can mask respiratory depression's effects on oxygen saturation values. We see similar statements on the procedural sedation side. For example, the American Society of Anesthesiologists Task Force, which included 6 cross-specialty societies, recently issued a statement on this, as did the European Society of Anesthesiologists, the Society of Gastroenterology Nurses and Associates, and these statements have been corroborated by folks on the interventional radiology side as well at both the nursing and physician level. Beyond the societies just mentioned, we see here that there has been a remarkable growing wave of capnography society standards, guidelines, and recommendations this decade alone. This is a global listing with North American statements in blue, European in red, and other global statements in light blue. This listing reflects the evidentiary basis and expert clinical opinion are converging on the point that capnography is a necessary part of the pathway towards early recognition and intervention for respiratory compromise. These statements can be further broken down to show that the ones in purple are related to sedation and those in orange are related to opioids. To select the ideal patient monitoring, we need to consider several factors. First, if the technology provides key parameters continuously and non-invasively. Then we need to think about its sensitivity. That is, its ability to pick up when respiratory compromise is present and have a low rate of false negatives. We additionally need to consider specificity because it's important that monitoring not produce false positives that result in alarms that are not actionable. Beyond sensitivity and specificity, an ideal monitor should have high reliability and a fast response time. We can look at this table as an example of how monitoring modalities perform for detecting postoperative opioid-induced respiratory depression. First, when we look at clinician assessment, we know that very skilled clinicians are able to identify and react to respiratory depression pretty well, but in particular, the response time is still going to be slow. There are now additional technological methods to assess parameters such as respiratory rate and tidal volume that are beginning to show promise. Pulse oximetry remains a staple in clinical monitoring because of its high sensitivity and relatively fast response time, but it remains a concern that supplemental oxygen often renders it to be a lagging indicator. With respect to ventilation monitoring, this can be done transcutaneously or by arterial or venous blood draws, but these all have slow response time, leaving end-tidal carbon dioxide for both intubated and non-intubated patients as the fastest means to identifying respiratory depression. Let's take a look next at how waveform capnography specifically can help provide actionable early warnings to respiratory compromise. So we're going to look at the following 5 interactive waveforms. When looking at a complete normal capnogram, the frequency should match the patient's respiratory rate, and the height of the waveform should be between 35 and 45 millimeters of mercury, which is considered a normal EtCO2 reading. In the case of apnea, when a patient has no breath for 10 seconds or longer, here's an example of what a waveform may look like. The patient has a normal waveform, then during a period of shallow breathing has a series of short, non-plateauing waveforms. During these short, non-plateauing waveforms, CO2 accumulation occurs in the bloodstream. When a patient takes a normal plateauing waveform breath, the CO2 will be elevated as they blow off what has been retained. In the case of partial airway obstruction, the breathing pattern is usually regular, so it occurs approximately once every 3 to 5 seconds. The waveform becomes erratic, progressively more dampened, and returns to an increased height as retained CO2 is eliminated. Hypopneic hypoventilation combines shallow breathing and bradypnea, so a low respiratory rate, less than 12 breaths per minute. The shape or morphology of the capnogram is typically abnormal, with short, non-plateauing waveforms and a slow respiratory rate. This is going to be followed by a higher concentration of carbon dioxide when a deep breath is ultimately taken. This is often seen during procedural sedation or with the use of opioids. In the case of hyperventilation, we see a low carbon dioxide level that results from excessive elimination through rapid or deep breathing or from metabolic acidosis. The breathing pattern here is usually somewhat regular. The hallmark sign of hyperventilation is a decreased carbon dioxide level below 35 millimeters of mercury in the presence of normal perfusion, circulation, and metabolism. When thinking through implementation of continuous non-invasive respiratory monitoring, it's important to think through considerations such as the alarm annunciation, whether that will be to a central station or a mobile device, and how those alarms will be routed, possibly delayed and even escalated. Alarm management is also important because threshold alarm limits in particular will influence the number of non-actionable alarms clinicians receive. Lastly, clinical decision support tools such as smart alarms based on fusion parameters, which combine multiple standard cardiorespiratory parameters, have the potential to reduce alarm fatigue, as do decision support tools that integrate data from multiple devices and automate known multi-parameter scoring systems that we've discussed, like early warning scores. Remember, if you're not remotely monitoring your patients, you're simply spot checking a continuous monitor every time you stick your head in the room. In summary, respiratory compromise happens frequently in acute care and sedation. It represents a substantial burden to the healthcare system and is often fatal for patients. Respiratory compromise is frequently preventable when early recognition results in clinical intervention. And although there are many conditions that lead to respiratory compromise, it's helpful to remember that there are only 3 pathways to the development of respiratory failure. Finally, continuous patient monitoring is a part of the pathway to empowering clinicians to prevent respiratory compromise. With that, we thank you.